पार्ट आहे रेट्रोपेरिटोनियम. रेट्रोपेरिटोनियम इज बाउंड बाय द पेरिटोनियम अँटेरियरली. आत्ताच आपण पाहिलं याच्यामध्ये पेरिटोनियम अँटेरियरली अँड इलियोसोअस अँड लार्जर मसल्स पोस्टेरियरली. द डायफ्राम इज द सुपेरियरली अँड लेवेटर ॲनी मसल्स आर द इन्फेरियरली. तर यालाच आपण बोलणार या सगळ्याला ते म्हणजे रेट्रोपेरिटोनियम. पुढे पेरिटोनियम असणार. पेरिटोनियम प्लस इलियोस अँटेरियरली. मागच्या साईडला मात्र इलियोसोआस आणि लंबार मसल्स असणार आहेत. डायफ्राम सुपेरियर अँड लेवेटर आणि मसल्स इन्फेरियरली. इट इज डिवायडेड इंटू द 3 स्पेसेस: अँटेरियर पॅरारिनल स्पेस, पेरिरिनल स्पेस आणि पोस्टेरियर पॅरारिनल स्पेस. 3 स्पेसेस: अँटेरियर, पोस्टेरियर, पेरिरिनल आणि खालचावाला एक अजून एक. सो ते झाले तिघे. सो दॅट्स द सुपेरियर, इन्फेरियर वगैरे हे सगळं. ठीक आहे. सो किती स्पेसेस केले आपण? अँटेरियर प्री रॅनल स्पेस, रॅनल म्हणजे किडनी. सो किडनीच्या वरचा दॅट इज अँटेरियर प्री पॅरारिनल स्पेस, परत पेरिरिनल म्हणजे किडनीच्या शेजारचा आणि पोस्टेरियर म्हणजे पाठीमागचा. द अँटेरियर पॅरारिनल स्पेस refers to the area anterior to the renal fascia but posterior to the peritoneum. काय म्हणलं आपण? अँटेरियर पॅरारिनल स्पेस म्हणजे काय आहे तर एरिया आहे अँटेरियर टू द रिनल फेशिया. अँटेरियर टू द रिनल फेशिया, तिथून तो रिनल फेशियापासून जाऊन तो जातो बट पोस्टेरियर टू द पेरिटोनियम. हा झाला रिनल फेशिया टू द पेरिटोनियम. This area contains a ascending and descending colon. Ascending and the descending colon. Duodenum, pancreas. The posterior to this space, the perirenal space. Posterior to the anterior pararenal space, renal fascia to the peritoneum. So this area ascending, मग काय काय त्याच्यामध्ये तर ascending colon, ascending descending colon, duodenum and the pancreas. Posterior to this space, perirenal space, which houses inferior vena cava, aorta, kidney, adrenal gland. The posterior pararenal space is a community, pararenal space, perirenal, the pararenal continuity of the preperitoneal fat of the anterior abdomen. Preperitoneal fat of the anterior abdomen, that is the pararenal space. Posterior. Give the compliance of the anterior boundary of the retroperitoneum and rigidity of other margin. Tumor, hematomas, abscess tends to expand anteriorly towards the posterior cavity. सो याचं कळलं काय आहे ते. तर याचं असं आहे की हा आहे अँटेरियर रेट्रोपेरिटोनियम. आता आपण ह्याच्यामध्ये बघू शकतो रिनल फेशिया टू पेरिटोनियम दॅट इज अँटेरियर पॅरारिनल. पेरिटोनियमच्या पाठीमागचं हे पेरिरिनल आणि एकदम लास्टला जे असतं ते असतं पोस्टेरियर पॅरारिनल. आता कशामध्ये काय काय हे पण पाहिलं आपण. तर हे अँटेरियर पॅरारिनलमध्ये हे सगळं असेंडिंग डिसेंडिंग कोलॉन, डिओडेनम आणि पॅन्क्रियास. तेच जर पेरिरिनलचा विचार केला तर इन्फेरियर वेना कॅवा, वॉटा, किडनी, ॲड्रेनल ॲड्रिनालिन ग्लँड हे सगळे सापडतात आपल्याला. पोस्टेरियर ही कम्युनिटी प्री पेरिटोनियल फॅट आणि अँटेरियर ॲब्डोमेनच्या मधली. गिव द कंप्लायन्स ऑफ द अँटेरियर बाउंड्रीज of the retroperitoneum and rigidity of the other margins. Tumor hematomas abscesses tends to extend arterially towards the peritoneal cavity. With the expansion of minimally invasive technique in a surgery, the retroperitoneoscopic approach has emerged as a potential modality for access of the retroperitoneum organ. Patients are positioning in the prone to lateral decubitus position. The retroperitoneoscopic approach allows access to the kidney, adrenal gland, and reperitoneal lymph nodes. One systemic review found no difference when comparing the laparoscopic and retroperitoneoscopic and to the retroperitoneoscopic adrenolectomy. The terms of the operative outcomes, complication, post-operative recovery. The retroperitoneoscopic approaches did, however, lead to shorter hospital stay, likely because reducing the post-operative pain. The measure of the studies eventually the retroperitoneoscopic approach are retrospective. More randomized trials are needed to provide further guidance. The retroperitoneal infection of the retroperitoneum can due to the primary hematogenous spread of the microbes and due to the secondary infection from the retrooperational and nearly organism. Retroperitoneal and nearby object. That's the secondary. It's a first, that's a secondary. Spread microbes वगैरे आणि हे nearby the organs. Example include a abscess due to the perforation, retroabscess due to the perforation of the retrocecal appendix, diverticulum, and the congenital perforation, duodenal ulcer, iogenic perforation of the gastrointestinal tract, pancreatic. Patients may develop back a plank on a growing pain and suffer from a fever chill. Depending on the severity, patients may present with a fulminant sepsis. Abscesses may become quite large given the substantial retroperitoneal space. On a physical exam, patients may present with erythema umbilical forms. The abscess can usually found on CT scan of the abdomen with a CT contrast, which can also show if the collection is loculated. The treatment of the retroperitoneal abscesses, including a source control via treatment of the underlying condition, drainage of the well-defined collections, and IV antibiotics. Image guided drainage is preferred. But it may be unless the abscess is multi-loculated in inaccessible area. For these cases, operative drainage may be required. Given the insidious nature of this disease and lack of the abnormal findings of the physical exam, recognition of the retroperitoneal abscess may be delayed. Delayed in the diagnosis, insufficient drainage may lead to the high morbidity and mortality. Depending on the severity, mortality, retroperitoneal abscess can be as only high 25% rarely. Patients may develop a necrotizing fasciitis of the retroperitoneum condition, high mortality. The peritoneal fibrosis. Fibrosis is a rare disorder characterized by the inflammation and the fibrosis of the tissue of the retroperitoneum. It exists as spectrum of the disease with chronic periortitis, which affects the retroperitoneal tissue near a large artery of the retroperitoneum. The fibrosis gradually expand encasing and uterus, inferior vena cava, aorta, mesenteric vessels, symptomatic vessels. Bilateral involvement is noted in up to the 70% of cases. The condition may either be idiopathic or due to the secondary cause, including the aortic aneurysm, pancreatitis, certain drugs, ergot derives, B blocker, hydralazine, methalodopa, others. Malignancies including the lipoma, carcinoid, sarcomas, colorectal, breast and other. The infections may as a tuberculosis, radiation, retroperitoneal hematoma, surgery, abscess, tobacco use. The retroperitoneal fibrosis can lead described in association with several autoimmune disorders include ankylosing spondylolisthesis, sympathetic, the systemic lupus erythematosus, Weber granulomatous, and polyarthritis nodosa. The idiopathic retroperitoneal fibrosis accounts 70% cases and thought to be a immune-mediated disorder. The theories regarding the pathogenesis idiopathic fibrosis of the retroperitoneum include exacerbation, local reaction, and aortic and iliac atherosclerosis, autoimmune depositions, fibroinflammatory cytokines. हे important आहे. The retroperitoneal fibrosis is also manifestation of the IgA-related disease, multisystem disease, characterized by the lymphocytic infiltration and variable degree of the fibrosis and several affected organs. One study has associated retroperitoneal fibrosis with HLA-BL, which has been linked to the autoimmune diseases such as symptomatic lupus erythematosus, type 1 mellitus, The idiopathic retroperitoneal fibrosis is rare, with the incidence of 1.3 into the 1 lakh people per year. It most commonly affects individuals in 4th to the 6th decade. Some studies suggest 2:1 male to female, but others have not a gender. Patients with this condition present with a non-specific findings. Most patients are diagnosed after the ureteral obstruction. Patients may complain of dull, acute back and flank pain. Systemic complaints are anorexia, weight loss, nausea, vomiting, fever, malaise. Decreased urinary output may ensure the ureter become fibrotic because of the renal artery impingement. Patients are commonly hypertensive. On a physical exam, findings include a lower extremity edema, diminished lower extremity pulse if the vessels of the lower extremity are compressed. New hydrocele, varicose can also be associated with the fibrosis of the retroperitoneum. Laboratory analysis is also non-specific. If there is a renal obstruction, patients may have elevated serum blood urea nitrogen elevated and a creatinine. The erythrocyte sedimentation rate and C-reactive protein elevated in most conditions. Anti-nuclear antibodies may be also elevated and highlighting the autoimmune. The contrast CT scan is a modality of a choice to visualize extent disease. The CT scan, the fibrotic retroperitoneal appear to have a similar attenuation of the muscle tissue. The fibrotic mass can appear to in case of the aorta often compresses inferior vena cava. If the renal insufficiency preclude the use the IV contrast. MRI can use to clarify extent fibrosis. Renal ultrasounds can also be used to document urethral compression hydronephrosis. In some cases, compressing the mass lesions can also be found on abdominal ultrasound, lower extremity ultrasound, and show a deep venous thrombosis. Pathological examination of tissue is necessary to confirm diagnosis and rule out the malignancy. Differential retroperitoneal masses include lymphomas, sarcomas, desmoids. इथे पण त्यांनी दिलंय की हे कसे ऑर्टाच्या कॉमन इलियाक आर्टरीच्या कडेला गेले ते. Tumors and the infections such as the tuberculosis. The biopsy can obtain either via image-guided or surgical techniques, which may perform laparoscopically during the open procedure. Once the diagnosis retroperitoneal fibrosis is established, treatment is initiated. Surgical treatment is aimed to relieve a ureteral obstruction either by uterolysis or a stenting. The surgery reserved for the patients who develop a renal insufficiency. Any surgical intervention in the patients carries several associated risks. In a patients with secondary fibrosis, treatment aimed at underlying etiology or discontinuation of the causative medication. For patients with idiopathic retroperitoneal fibrosis, corticosteroids are the mainstay treatment. The patients usually started on 1 month of higher dose of the prednisone, followed by the maintenance therapy and subsequent the tapering. Alternatively, the tamoxifen can be used if the patients have the contraindications to the steroids. Within a days of the instituting therapy, symptom inflammatory markers should be improved. Over the course of a few weeks, renal function should improve. Interval imaging studies are usually often after 1 month of the evaluation in efficiency. If steroid fails to cause a regression of the disease, patients can be started on the immunosuppressant medication, including methotrexate, azatropine, cyclophosphamide, myophenolate mofetil, and recurrence retroperitoneal fibrosis varies between the study 10 to 30%. Respond to steroid therapy, 5-year survival rate are the higher. So आपण आता इथे काय काय बघितलं. Steroids fail, often 1 month evaluate efficacy. Steroids fail to regress. Patients started with the immunosuppressant medication, methotrexate, azathioprine, cyclophosphamide. स्टेरॉइड थेरपीमुळे 5 yearची सर्वायवल रेट वाढतो. तर अशा प्रकारे आपण हे सगळं बघितलेलं आहे. इथले थोडे राहिले हे आणि आपण चॅप्टर हा कंप्लीट केलेला आहे.